Healthcare is quietly rewriting the rules of where surgery happens, and many organizations are not fully prepared. In this episode of The Architecture of Healing, I step away from the interview format to share why this podcast exists, why now is such a critical moment, and why these conversations matter. I then unpack one of the most consequential shifts in modern care, the rapid evolution of ambulatory surgery centers. From the origins of the ASC to the 2026 CMS rule and the impending end of the Inpatient-Only list, I explore how policy is reshaping strategy, space, and the future of surgical care. Let's get into it. Welcome to the Architecture of Healing. Today's episode is going to be a little bit different than our usual interview style episodes. I'm going to share a little bit about a topic that's been on my mind lately with respect to ambulatory surgery centers and some of the recent work that I have been doing. But I also want to take a minute and dive into the podcast and why I have decided to launch the Architecture of Healing podcast. First off, thank you all for joining. This has been a really fun start to 2026. And as you know, we launched this podcast in the fall and have built up some great momentum. I've got a number of questions from many folks about why start a podcast? Why is this something that you are doing now? And I want to share a little bit about that and my vision related to the Architecture of Healing. I've had this in my heart for probably 5 years. A podcast has been something I've been very intrigued by and I've really been interested in doing. I've been a huge podcast guy for a long time. I've listened to a number of them. I follow quite a few regularly on my long commute to and from work every day. So it's been a great outlet for me and a huge way to learn about topics that I'm very interested in and just continue to grow my own personal expertise. And so I thought I could use this as a platform to really elevate the industry related to healthcare strategy, planning, and design. Some of the things that I am really passionate about doing on a daily basis, the conversations that I have with leaders and executives and designers on how facilities are operating and functioning, I would love to bring those to everyone else, to share some of the things that I'm hearing in the industry, but then also learn from all of you. What are things that your organizations are working on or putting energy and thought into and elevating? How is care evolving over time with changes in regulatory requirements, with changes in consumer preferences? What does that look like? How does that impact healthcare strategy? How does that impact care delivery? And ultimately, how can space and the built environment support that care in a healthcare setting? So that's really what I've wanted to do here with this podcast, to create a platform to allow conversations to take place, to allow learning to occur, to create space for ideas and share knowledge. This is a space that can really be used to challenge one another, challenge ourselves, to move the industry forward and share knowledge, taking what we've learned in different areas and sharing that with the broader community, not waiting till a conference to have that conversation with a colleague that you see every so often, but creating space for those to happen in real time. And additionally, for me, learning is a passion of mine. I want to grow my knowledge base and my skill sets equally as much as you do. So I hope that this is a space where we can all collaborate, share knowledge, move the industry forward, and challenge some of the norms that we've come to know. I would love to hear from all of you that are listening. If you have ideas, thoughts, comments, topics that you're interested in that we can dive into. This is really a community, and I want to create a space for that community. I'm so happy that each of you have joined the conversation, following on YouTube, Spotify, and Apple Podcasts, and checking us out on a regular basis. So again, don't hesitate to reach out if you have questions, want to learn more about the podcast, or have thoughts to contribute to the conversation. I'm hopeful that as we do this, this is going to inspire new ideas, new ways of thinking across the board, and really a rising tide lifts all boats. And so as we continue to push one another and challenge one another, it's going to grow us collectively as healthcare planners, executives, leaders, designers, clinicians, operators, whatever you might be, and move us forward. So that's a little bit about my story. My background, I've been doing healthcare architecture and design for about 15 years. Really kind of fell into it. When I was in school, there was a healthcare studio that was offered. Shout out to Professor Bill Warren. It was just a crash course in healthcare design. Here, design a hospital in one semester. That was a gargantuan task. We were provided a program, a performa, and asked to completely design a hospital with zero knowledge about how hospitals work. And so that was just immersion by fire. And ever since then, I've been sold out on this healthcare thing and growing my knowledge not only in design, but in healthcare as a business and how we as designers can support business goals of healthcare organizations. I've had the opportunity to work on some incredible projects, new hospitals, vertical expansions, major additions and expansions, and then renovations and master planning. And master planning has been a huge passion of mine to really think about the healthcare organization and the healthcare facility as a strategic component to the business. How do you support the care of the patients in your community through a smart master plan? How do you think about your master plan in terms of the goals the organization has and position the organization to succeed 5, 10, 20 years down the road? And so that is something that I've really, really enjoyed. It's provided an opportunity to learn about every component of a healthcare facility and a healthcare system. Today, I also wanted to share about a topic that has been top of mind lately and that I've been spending a lot of time thinking about, and that's ambulatory surgery centers. There have been some changes here legislatively and with Centers for Medicare and Medicaid over the last few months and into 2026 that I am going to break down here. But before we do that, I want to give a quick history of the ambulatory surgery center and how we've come to this place of outpatient procedures in this ambulatory setting. So in 1970, the first ASC was opened. Two physicians, Dr. Wallace Reed and Dr. John Ford, began rallying support for this new concept of outpatient surgery. There was a big push for more affordable care, better access to care, and quality outpatient alternatives to what was traditionally a longer inpatient stay for many smaller minor procedures. These two physicians worked diligently to raise some funding and ultimately opened up the first Surgery Center or ambulatory surgery center in performing cases in this ASC, and they had the support of more than 40 insurers or payers. A few years later, in 1973, the American Society of Anesthesiologists established some standards around safe and appropriate care in the ambulatory surgery centers and how they might support those surgeons and physicians with that level of care. By 1975, a total of 42 ambulatory surgery centers had opened, and an additional 25 were opened in 1976. In the late 70s, ambulatory surgery centers then became accredited through the Joint Commission as well as the Accreditation Association for Ambulatory Healthcare. This was a huge step and provided some oversight and regulation to these facilities. By the early 80s, CMS had approved payment for approximately 200 procedures, and by the late 80s, this list expanded to over 1,500 procedures. In addition, by 1988, the number of ASCs had reached 1,000, with Medicare implementing a new payment system for ASCs, which actually still remains the same payment system today. So, pausing for a moment, we went from no surgery centers in 1970 to 1,000 in 1988. In 18 years, we built 1,000 ambulatory surgery centers, developed a process to deliver safe outpatient surgical care as well as affordable outpatient surgical care through Medicare reimbursement payment models. Moving into the 90s, the covered procedure list expanded to over 2,000. And as another measure of safety in the 2000s, or in the year 2000, CMS created the Inpatient-Only list, and this was a list of procedures that were deemed too invasive or may require too significant of a recovery time to be performed in an outpatient setting. So these were procedures reserved specifically for that inpatient setting. Moving on, 4 years later, by 2004, more than 4,000 ASCs had performed over 8 million surgeries annually. And in combination with that inpatient-only list, CMS also built out the covered procedures list, which by that time in 2004 was able to reimburse more than 2,400 procedures. By 2010, the number of ASCs in the United States exceeded 5,000. And by 2011, 5,300 ASCs were performing 23 million surgeries annually, with that covered procedures list accounting for about 3,500 different procedures. In 2018, this is where things begin to get interesting. There was discussion about removing that inpatient-only list that was created in 2000. And that's evolved over time with the removal of some procedures from that list. And in 2020, CMS announced the intention to eliminate this list and begin phasing it out. This really started with the total knee being removed from that list, as well as a few others. And then in 2021, they removed around 300 procedures from that list. However, later in 2021, CMS reversed course. There were many concerns around patient safety and efficiency of the ambulatory surgery centers. They reversed course and decided not to remove that inpatient-only list and maintain some of those procedures. And so many procedures were added back to the list later in 2021. Fast forward to today, fall of 2025, CMS has announced their intention to again remove that inpatient-only list. With the 2026 rule, CMS is removing 285 procedures from that inpatient-only list and again has announced their intentions to eliminate the list by 2028. So some of those procedures we'll dive into here that will be immediately impacting this next year, but that's a big deal. By removing that inpatient-only list by 2028, that changes dramatically the landscape of hospital surgery centers, ambulatory surgery centers, and inpatient surgery. There are a lot of impacts to that from a financial perspective, patient perspective, and facility perspective. One, we're going to need a dramatically increased outpatient capacity in surgery centers. What is happening today is going to be exponentially greater. That shift, as you can see, going from one surgery center in the 70s to over 5,500 or 6,000 today, that's going to keep going and keep moving forward. That's also going to reduce the demand of some of the surgery spaces within our hospitals on the inpatient side with those procedures moving to outpatient. I personally also think it's going to drive some innovation with some of the procedures that are currently happening inpatient. There may be this desire for them to move outpatient. However, they are maybe a little more invasive or they are requiring longer stays in a hospital. How do we conduct those surgeries differently? Is there different procedures that we can take to make those shift further from an inpatient setting to an outpatient setting? So we could see more innovation with how care is delivered and how surgeries are conducted and procedures are conducted in order to help this move a little bit further. Reimbursement risks. I think this is also a big one. With this list going away, insurers are going to be less inclined to pay for higher cost settings. They're going to want, if at all possible, to reimburse for these procedures in outpatient settings at a lower cost. So what does that look like? When you do have inpatient procedures, there's going to be a greater demand for proper documentation of why it's in an inpatient setting. Why does this procedure require extended stay following the procedure, going back to the 2 midnight rule, which I won't get into today, but really documenting why that patient will need to be in the inpatient facility for over 2 midnights, essentially over 24 hours. And really documenting why that procedure cannot be performed safely in an outpatient setting. The onus is going to be on the physician in the facility to provide that information to justify the site of care. Additionally, as part of the 2026 rule, there's some continued movement to expand that site-neutral payment policies, less so on the facility side and more related to drug administration with 2026, but you're continuing to see this movement of site-neutral payment policies. So essentially, why are we paying more for procedure A in an ambulatory surgery center connected to a hospital versus procedure A in this ambulatory surgery center half mile down the road? So thinking about equitably reimbursing procedures regardless of the site of care. Now, this creates some complexities within the facility, knowing that ambulatory surgery center at a hospital or in a hospital is significantly more expensive to construct and operate than an ASC freestanding down the street without those same resources and staffing models. There is a trend moving to site-neutral payment policies, and it's something that is important to watch over the next several years to see how it evolves. So specific to the 2026 rule, as I mentioned earlier, some of those new procedures that are coming off that inpatient-only list and now being recognized or reimbursed in the ambulatory surgery center setting include some cardiology procedures and cardiovascular codes, such as electrophysiology studies and ablations, cardioversion, and transesophageal echocardiograms, to name a few, in addition to some spine codes and some vascular codes. So there's a number of new procedures that are now coming to the ASC setting that are causing ASC operators to think a little bit differently about how they operate these facilities and the types of patients. And strategically, do they need to grow, add space, align with different physician groups? It creates some new questions that are interesting to think about as we start this year and perhaps changing the strategy of some organizations. That said, you need to consider those physician groups and how they're operating. For example, do you want to create a cardiac ASC? Maybe, but I think traditionally some of those higher acuity level types of or more invasive types of cardiac procedures, those physicians are going to want to stay close to the hospital so that they have that connectivity. So there may be other factors besides these reimbursement scenarios to consider when thinking about those overall strategy ideas. But why is this important? All this information about ambulatory surgery centers and its impact over the last 50 years or so. What does that mean for today? What does that mean for the future? With the evolution of the inpatient-only list and the removal of it, so to speak, it's really elevating the need for ambulatory surgery centers and taking care out of the hospital and to a lower cost side of care ultimately to make care more affordable. But how does that impact our hospitals? I personally have always been advocating the hospital of the future really is three things. It's an ICU, it's an emergency department, and it's surgery. You may have a little imaging sprinkled in here and there, but it's really, really stripped down because we are seeing so much care moving to outpatient sites that your hospital is becoming much more acute and thus not needing all of these different parts and pieces that are really shifting to that ambulatory or outpatient care setting. How do we think about that in terms of future development of facilities, future alignment with outpatient settings, and overall master planning? There's still a lot of value in co-locating surgery centers and the hospital, co-locating outpatient specialty care clinics with a hospital. It's not just about the reimbursement, but it's about staffing, physician alignment, co-location, overall efficiency in care, also layering in the education component if there is an academic medical center. What are all of those other parts and pieces that you must layer on to really think about that? But ultimately, the landscape of care is changing, and as a designer, I feel it's important to really understand how that's changing so that we can support healthcare organizations in the best way possible and advocate for their strategy and advocate for an efficient means of delivering care at the greatest value for them, whatever that may look like over time. So that's why I feel like this is so important. And I hinted at it towards the beginning, but the project that I'm working on does co-locate an ASC within a hospital. It's got proper codes. It's got the 1 hour fire rating around it, all that good stuff. And it's owned and operated completely separate from the hospital, essentially treated as a tenant within the hospital. And It's a really unique concept. It allows for flexibility should the ASC grow. The way it's set up is married to the hospital surgery department, essentially. And so there are mechanisms to flex 2 ORs to hospital, 2 ORs to the surgery center as needed over time as care evolves. So this is a really unique model. It gives a lot of flexibility to accommodate things, such as what we're seeing with the trends for ambulatory surgery centers. And as this evolves and continues to evolve, you can tweak the dials and change the levers to really adjust your strategy and adjust the way that you care for patients without having to completely overhaul your space and your facility. So I'm really excited to see how that plays out, especially with these new guidelines and these new changes with CMS and the 2026 rule. If you're growing your ASC capacity or working with organizations to expand ASC footprints based on some of this, I'd love to hear from you. I'd love to hear about what your organizations are doing to move the needle on growing outpatient capabilities in the surgery center. And also, what's that doing to hospital outpatient departments? How is that impacting their volumes, their workflows? Are we seeing a reduction in the demand for that space? Very curious to hear what others are seeing and how other organizations are adapting to the 2026 rule from CMS. I'm sure it will continue to evolve over the rest of the year, but excited to see how that takes shape. I know this has been a lot of information very quickly here with the background and history of surgery centers, as well as some of the recent changes with CMS. So I'm going to put a link to several resources in the show notes for you if you're interested in diving more into detail and seeing more of the backstory with all of this, as there's a lot to dig into. So hopefully that will help you if you would like to explore further more information on this topic and dive into it. Thanks for joining us today on the Architecture of Healing. I know this has been a little bit different episode. I'm hopeful that over the course of this year, I'll be able to do a few more of these solo episodes where we do a deep dive into a few different topics. If there's a topic that's of interest that you would like to dive into further, I'd love to hear from you, and we can spotlight that, dig into that, and really go deep on them here. And if you have thoughts or feedback or comments on this episode and ASCs, I'd love to hear from you as well. What are you seeing with your organizations and your clients? How are you seeing people adapt to the new 2026 rule from CMS, and how is that impacting the landscape in your region or with your organization? It'd be great to see that. Love to share that with the listeners and really continue to make us all better and grow the collective body of knowledge. So thank you again for joining us today. Look forward to catching you in a couple weeks for our next episode. Thanks for joining us on the Architecture of Healing. I hope today's conversation brought you fresh insight and inspiration. If you found this episode valuable, make sure to subscribe, download, and give us a review. Want to learn more? Keep the conversation going and head on over to thearchitectureofhealing.com. We've got more great conversations on the way, but until then, keep shaping the future of care through thoughtful strategy, smart operations, and purposeful design.